Hey there. Yeah. It's so funny to me. Like everybody comes back so like, right? Whatever y'all are talking about, I'm not, we can't like hear or read any
Yeah.
of that stuff. So I love that y'all have that space to be like, Kitty is crazy. What is she talking about? Like, this is wild. Oh,
Was gonna say it's energizing just to talk about it versus
hmm.
listen.
Yeah. Yeah, totally. I also think too, like there's an element of it like we're so siloed and disconnected. Like, we're in our rooms by ourselves, and
Hmm.
maybe we're a solo practitioner, so we're really alone, or we work at telehealth only. And so some of that I think too is helpful just in reconnecting. Okay. So, we had really great questions come in through the chat. So I do, through the over the weekend in email and chat. So I want to just take a moment, right, to ask if there's any really burning questions that people want to make sure we get to today. I've got all the ones in the, like I said, that came in over email. Are there any? I saw one come in the chat too. So, is there anyone else or any other questions?
I
Yeah.
I don't know if this is one, but the documentation, I had a client come in with um, body dysmorphia and that, and wanting to be female and that. How, with everything going on with trans, how we look at that.
Yeah. And I can answer that pretty quickly, actually. We talk about it as we would with anyone exploring their identity. So it's really identity because when we get to the core of the issue, right, it's an identity exploration concern. And we can absolutely talk about it in that way. Yeah. My philosophy is we don't need to talk about the details, right, of like medication and things like that. Frankly, that's out of my scope of expertise. And so I don't want to put it in the documentation and confuse that for whoever might be reading it in the future. I'm not a doctor. I don't deal with meds. So I just kind of, other than an update of like my dose changed or I started a new med, like that's really all I need to know. Yeah. Patrice, I saw you had come off mute. Did you have a quick
It
one?
just a really quick one. It might be well, anyway, because we have an upcoming Medicare audit coming up. And I was asking what do you want to make me to make sure when I go over my notes? The difference between having the treatment goals and the treatment plan.
Hmm.
Because again, just as we've been doing this, I've always just put in my treatment plan and not actually always put in treatment goals. So I mean, do you have both of them? So, anyway, I'll let you answer that.
Yeah. So they were asking what's the difference between a treatment plan and goals?
No, I'm asking, I guess, what is like when I asked her who's doing the auditing, one of our colleagues, I said, what,
Ooh.
she said treatment goals. And I was like, that's different than the treatment plan.
Mm. So the
So see
treat
that, yeah.
Yes, I think I see what you're saying. So we're gonna, like I said, next week, and y'all get a discount, by the way, that's something like 10 or 15% off. I'll have to look that up if you want to do the treatment planning, because that will go into like how do we really, conceptualize the entire arc of
Mhm.
treatment kind of a thing. So one thing that may be helpful as a frame of reference is part of what we are doing is reclaiming, right? So remember last week we kind of talked about how our stuff, the mental health therapist got lumped in with doctors.
Mhm.
And what we're doing is actually kind of at the core of identity and personality and spirituality and all of those things. So the treatment plan that you put in your documentation is very cut and dry, and it's that particular line, sufficient for Medicare, by the way, because we do it and we accept Medicare as well,
Okay.
is clinician will utilize modality of choice, right, to
Mhm.
facilitate presenting issues and symptom reduction, kind of a line. So that line in there is your plan. It's
Mhm.
not, and it doesn't need to be, right? This is a total shift from what we've probably all been told, which is it should be like very outcome oriented. That's actually rooted in, I was about to say like patriarchy. And, sorry, my inner social worker was coming out.
No, you're good.
I mean, kind of is, but it's really rooted in cover your butt kind of mentality, protective, not of the client, by the way, of the agency,
Hmm.
of the insurance, right? Things like that. And so the insurance is going to come in and be like, I want this and I want that and da 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 da, right? And this is where saying, great, show me where it says that in my contract that that is required,
Okay. Okay.
right?
Yeah.
Awesome. If you want this, this is what I need to see is exactly where does it say that?
Okay. Okay.
Yeah. How
That
does
helps
that?
me. No,
Yeah.
that helps me. Just again, and our
Good.
IMS system is super old. It's
Uh,
just and very antiquated, and it's like, and it's very geared towards because we do have doctors in our practice as well.
hmm
So
hmm
I'm trying to figure out how to use this in what I have, and I'm
Yeah. And so,
working at it, but it's
yeah,
difficult.
it is. And this is going to take time, right? Like,
Okay.
I'm not, what I'm, one thing I'm not handing you is just here's a blanket, here's a format, just do this and you're good, right? Really, what's happening is you're understanding a whole new way of understanding our documentation and the purpose of it, right?
Hmm.
This is a framework resetting. So I want to name that too. And
Yeah.
so if it feels like well, this feels like a heavy lift, this feels hard, yeah, because I'm not just saying, here you go, take this and go with it. We're thinking about how do I write this in a new way for clients.
Yeah.
So I also want to address working with doctors. So I was at UT Health Austin for a while as part of their integrated behavioral health program, and as a social worker embedded in teams of doctors and nurses and NPs and the like of that group. And there was one time I had a doctor come out, snapped his fingers. I kid you not, snapped his fingers. And like social worker, social worker. I need my patient needs a little CBT. Who can come do a little CBT with my client? And I was like, yeah, so back up a little bit, buddy, right? Out of your scope of expertise too. So you're gonna have people that come in and are like, you need to XYZ. You're the expert on your client and your population
Mhm.
and what your clients need. That doctor knows nothing about mental health for the most part, despite what they think. And so you get to say, no, thanks. Actually, here's how this is going to go with my client. As far from the mental health, right? Like own your scope of expertise. You can do that, even if they don't want you to. And we can all sit and talk about how that feels, but that's not this kind of a group. I'm sorry.
Thank you very
Unfortunately.
much. That really helped.
Yeah, good. I'm so glad. Okay. So I see several questions in the chat. And so where does a private practice, let me answer, see if I can do these right off the cuff. Uh, do group notes. Ooh, I was like, wait a minute, what? It started like popping up more stuff. Okay. That was last week. Does this weird thing in the chat where it like goes to last week. So my apologies. I'm scrolling back to today. Okay. Progress to Okay, so do group notes stay the same as individual notes? That they can actually. In fact, when I've done groups, that is part of how I lay them out. Is I use the same or a similar structure as this document, and I still am only changing that one line, right? Of like, what did I do, kind of a thing. And I might make a note on. Although no, I probably keep this in my psychotherapy notes, kind of the tone or the group or the energy of the milieu kind of a thing. But beyond that, no, because our documentation is for the government, right? Like I kind of think about it that way. It's legalistic. In fact, sometimes I think of us as speaking in two languages, right? One is for the technical documentation, the legalistic part of it, and the other one is for us and our internal process, kind of like our journal. Um, do you address progress notes towards goals in the documentation? My current template has a section for progress. So we don't in our practice. What I use for that is those quarterly, although sometimes people do it monthly. And I think that's probably a pretty good idea too, of PHQ-9s, G87s, whatever kind of are your standard assessments that you do. We do a lot of PCL5s because we're a PTSD focused practice. And so we'll do those periodically or a DES, right? And track how those scores are changing. That's kind of our quantitative data about progress or lack of progress toward goals. It's also helpful for clients too. I've certainly had clients where if you've been working with them for a long time, the subjective experience, or if they're young, or if they have an alexithymia, things like that, the subjective experience of their depression or their anxiety may be hard for them to notice. And when you say, wow, 3 months ago, your score was this, and now it's this. What do you notice that's different, right? That's kind of how we can update that assessment piece and that tracking progress toward goals. For LGBT, therapist facilitated client exploration of existential themes. So we are totally going to get into that. In fact, I'm going to go ahead and pop into that and share my screen and see if we can get to some of those other questions as we go through it together. So give me 2 seconds to share my screen. All right. Great. Can everybody see this? Perfect. So you're going to get a copy of this, just so you know. If we don't get through the whole thing before we, need to pivot to the other document, just because of time, you're going to get this and you'll be able to spend a lot of time with it. So we're going to do last week, somebody had brought up the question around, or the topic around, like the client presenting in one way, and then the clinical observation being something different. So how would we document that, right? So the clinical scenario in this case study is the adult client in ongoing weekly individual therapy for major MDD with a history of NSSI and complex trauma. That's non-suicidal self-injury, which we can identify in a lot of different ways. That's really a subjective statement that you can make. Client denies any current SI today, but the clinician observes new superficial cuts on her forearm. Noticing like brief episodes of distracted gaze and consistent with full denial of internal stimuli, PHQ-9 score that's doubled, right? So the client wasn't even realizing that it had doubled since the prior administration of the test, despite the client insisting she's doing better. So this is so we've got kind of a before note, right? I don't know if any of you have written notes in this way. I've seen notes written this way in all of these examples, but this is kind of a before shot, right? Of like, client came in today saying things were fine and denied any thoughts of suicide. I noticed some new cuts on her arm. She said it was an accident from her cat. Seemed a little out of it today. She was looking at something across the room a couple of times. When I asked, she said no. So, her PHQ-9 was a 19, which is way higher than last time, but she insisted she's doing better than last week. We talked about coping skills. She seemed calmer at the end. No risk noted. I would say that's kind of a risky situation, but let's move forward to see what would that look like in our documentation. So you notice actually that we have more information in our documentation that is helpful and protective of what we need to report for, insurance, like length of time. So we've got that they attended in person, 53-minute individual session, or you could put the time on there. Some of our clinicians put the time that they met with the person. Her presenting issues are MDD with history of non-suicidal self-injury and complex trauma. Goals are to decrease depressive symptoms, self-injurious coping, and dissociative episodes. Client goals are to increase distress tolerance, safety behaviors, and reality testing grounding capacity. So this is their reasons for coming to therapy. Then and what are we doing here, right? That's part of the treatment plan. What are we working toward? What are the major themes, high level view of what we're working on? Our treatment plan, to get to the question from earlier: weekly 53-minute individual sessions utilizing DBT skills training and trauma-informed stabilization to reduce self-injurious coping and support emotional regulation. So you can see, right, that I put in there exactly what my plan is, what my modalities are that I'll be using, things like that, how often I want to see the client, and what I'm working toward. And if you notice, it's tied directly to the presenting issues and goals, right? So we've got a treatment plan tied to what the client wants to work on overall in therapy, not just that session, But also notice there's no language in there around what that self-injurious coping was, right? So that could have been speeding, that could have been gambling or addiction or, other things like that, banging their head, cutting, drinking too much to excess, right? So I'm saying what the theme of the issue is without the details of what the behavior is. Does that make sense? Is that landing for everybody? Right? Good. Therapeutic intervention. So this one is actually more extensive, right? And you're going to have notes like that to just really kind of match scenarios in this way. It may not be a one-liner in this particular case. So the clinician observed new superficial lacerations on client's forearm at session opening, conducted a direct self-harm and suicide risk assessment in response. I didn't say client came in today and said, I don't know what's going on in the world, right? None of that. It's all what did the clinician, what did I do? Clinician also observed brief periods of distracted gaze and delayed response to conversational cues during session and directly assessed for hallucinations. I saw it, I clocked it, I assessed for it, I met the moment. Clinician administered the PHQ-9, which scored a 19 out of 27, a marked increase from the prior administration, and reviewed this change with the client. The client is aware of the increase, right? Clinician utilized DBT, distress tolerance, and grounding skills to address observed present moment dysregulation, reinforcing grounding and self-soothing techniques to enhance emotional regulation, and reviewed and reinforced the existing safety plan. Clinician observed increased present moment orientation and reduced distraction in client by session close. So this is different, right? Because in the ones that we showed you from last week, those were simpler cases. You can see now when we have a more complex case, you can write more. Look at the way, and we're going to go through the way to talk about it. So know that we're getting to that. I just want you to kind of take this in what this can look like and how we talk about the overarching plan and what's going on. And then how do we meet the moment in that particular session? Because we talked about if the worst situation happens, and there's an investigation for some reason, what BHEC cares about is, did you see it? Did you clock it? Did you address it? Yes? Okay, you did your job. Just let that land. You did your job. It's not up to us, despite what clients and the others have said, to own the outcome. It's up to the client. They have self-determination. That's assuming your client's not like actively hallucinating. There are, that the client is of right mind and can give consent and revoke consent and all of those things, right? Let's keep going. So the medication updates, there weren't any referrals, none at this time. The clinician will continue to monitor and reassess need for psychiatric consultation given today's assessment score elevation. I'm clocking it, right? I'm tracking it. The assessments conducted, so here's just the score, here's the previous administration. You wouldn't even necessarily I'll highlight this piece, you wouldn't even necessarily need to put in there. But if that, especially some of us are working in collaborative settings, right? They may want that. It might make them more comfortable as we're stepping them toward this more minimalist documentation. You may have a boss who's like, I need to see more information, and you get to decide if that's a hill you want to die on kind of a thing. So these are kind of ways you can add that in there. The recommendations are to continue weekly individual sessions. Clinician will reassess safety and mood symptoms at next session given today's elevated PHQ-9 and observed presentation. Next is continue DBT skills work, re-administer G87. Maybe we only got to the PHQ-9 today, but we want to also check that anxiety and review safety plan at next session. We want to review the safety plan because we want to see, is it working? Did it help? Do we need to, adjust it in some way? Did the client follow it? Because we need to know that for trust and for capacity building and things like that. Did they follow it, or are they just like, yeah, I'll do it, and trying to people please with us? Because clients like to do that sometimes. I'm going to be the best client ever. Some of our perfectionistic clients. Client denied SI, HI, AVH on direct questioning. Clinician additionally documented an observed presentation. So you can see this section. I'm repeating what I observed. They presented at the beginning of session with reduced engagement, ended session alert and oriented ×4. They're coming back. Got our bookend. They came in. Here's how they're coming back. And then they left, right? And here's how they left. So this is a note. Down here, we've got also, sorry, I just pivoted on myself. Teaching points, which are just like things to kind of keep in mind how I'm thinking about this note, how I might write it, how I might consider it. You know, why did we add more information to this one versus others, and you know, things like that. So we go through kind of some of the whys of that, right? So like, you know, right here we've got the client denied the symptom. So I'm writing what the client said. Still worth documenting when there's a reason that you assessed for it, right? So you're calling out the mismatch without naming the client, right? Well, here's what the client said, but I don't believe them because, you know, clients or whatever, right? None of that is in there. Okay, before we go on to the next one, I want to check in. I'm going to stop sharing really quick. We have 2 more we can get through. So we can either pause here for some questions, or we can go on to the next 2 and kind of get through them, and then the language piece, and I can answer questions toward the end. What would you all like to do? You can just drop it in the chat, or, you know, thumbs up, or go through 2 more, or ask questions. Okay. All right. It looks like mostly keep going. So let's go through the other 2. Okay. Scroll down. So our case 2 has some of those identity and privacy sensitive disclosures. So this is an adult client, ongoing weekly individual therapy, relational distress, family-related anxiety, identity-related adjustment. Today's session touches on several areas a clinician might feel protective of. So
So
this
sorry to interrupt. I think we're on a different view.
Oh,
We're
okay.
not seeing
Let
we're not
me,
seeing the share screen.
oh,
Thanks.
thank you so much for popping in there on that. Okay, let me reshare. How about this? Can you see it? That is wild.
I think it's probably showing like a gallery view rather than a speaker view or something like that.
Yeah, it was
Okay.
showing you and the screen. So the screen was really small.
Interesting. Okay. How about now?
Yes.
Okay. Zoom gremlins, that's what I like to call them. Okay, so this is a client who is in a non-monogamous partnership. There is some immigration status concerns and adjustment to gender-affirming hormone therapy. So I really created this case study to kind of get at some of those questions and concerns around really sensitive topics, right? Like these are like three heavy hitters here. So we can see in that before note is really full of language around, you know, girlfriend and boyfriend situation, has 2 partners, like she has 2 partners, and there was some jealousy stuff going on this week. She's also, so we've got another thing I want you to notice in this particular note is there's a lot of gendered language. And our note format is ungendered. We don't use any pronouns whatsoever. So that in part is protective. Some of it is the genders are irrelevant. But I'll tell you the biggest thing that really made me really lean in this direction was having a transgender clinician who's a great friend of mine. We were talking about this very topic, and they said that, you know, if you're working with someone whose pronouns at the beginning of therapy are he, and then they go through transition, and at the end of therapy, they're she, that could be really triggering if they were to read their documentation. And so it was more sensitive and compassionate and trauma informed to withhold the gender pronouns. Now, I will also say that's a conversation that I'm having with clients. I'm like, here's how I navigate that. And it's for your protection. It is not for your minimization. So we talk and we process that together, we discuss it, all of those things. So I'm doing it in relationship and in service of the therapeutic alliance by having that conversation. Okay. I'm not going to go through the entire details of that before I know. Let's get to the good stuff because I want to spend time here. We've got the attendance. Notice how I'm writing the presenting issues and goals. Distress within intimate relationships, not naming what kind. Anticipatory anxiety related to uncertainty in legal, social, or economic status. Not talking about immigration, not saying we're worried ICE is going to come bang down our door, right? We're saying uncertainty in this environment. And adjustment to a recent change in medical care, because that is the high level view. It is irrelevant what kind of medical care it is. The type of medical care, for the most part, obviously, if that's a specialty of yours, that's a different scenario. But for the majority of us, we're not medical doctors, and so it is irrelevant to the work that we're doing. How is it affecting the clients presenting issues? Is the purpose of why we're talking about it. Goals are to decrease relational conflict and anticipatory family-related distress, and to increase communication skills, emotional regulation, and felt sense of safety and stability. So notice there's nothing in there about the immigration, nothing in there about hormone therapy, nothing in there about polyamorous or non-monogamous or whatever, right? All of those things are kept out. I've talked about the major mental health therapeutic themes that we're working on. Clinician plan, same as all of them, generally, that statement. And then the therapeutic intervention, clinician facilitated exploration of relational dynamics within the client's existing partnerships. Partnerships could be business colleagues, right? It could be roommates, it could be pets, depending on the person. Focusing on jealousy and communication patterns. Clinician also processed client stressors related to uncertainty in a family member's legal, social, and economic status, validating chronic hypervigilance and supporting development of adaptive coping strategies. Clinician utilized parts-based IFS exploration to support emotional regulation across all presenting themes. So again, this is kind of how we're keeping those details out. Now, in my journaling, my psychotherapy notes, not progress notes, psychotherapy notes, my journal that I'm writing in, I might write down 2 male partners, a male-female partner, 2 female, right? I might, put in those kinds of information of like those little nitty-gritty details so that helps me remember the VIPs. I think solution focused free therapy, the very important people in this person's life. What does that need to look like? Ages of kids, stuff like that. I might put that in there. Medication updates. Recent change to existing medications have been noted and updated. Now, this might be an area where we have some feelings about that, right? Because in every case, we are writing, what medications have changed. If we've written it for some medications and then we exclude others, that's going to look weird, right? So we need to be consistent in how we're doing it. So if you never put in medications that clients put in there, then don't put in medications, right? But if you typically do, put in the medication, and that might mean naming that medication, and that might bring up some feelings for us, for the client, and we can process that. But just notice that, we kept it pretty vague in this particular place. Our EHR is sessions, and there's a line where you can write in the specific medication and dose if you want to. So we have another place where we are tracking that, and this line would be sufficient. If your situation or your EHR doesn't have that, you might write in those medications right there. No referrals were made, no assessments were conducted. The recommendation is just continue with sessions. And in this scenario, they put on what they want to work on next, which is continue parts-based work on relational and family-related stress. Don't have to put that in there. You can if you want to. The risk and safety, no risk presented, denied, all the things, arrived and ended session, alert and oriented ×4, and coming back in 1 week. I see some questions coming in the chat. Lisa, are they ones I need to answer right now, or can I kind of go through the last scenario first.
Do the last scenario, and then I have been keeping track of all the questions, and then I can read them off to you.
Awesome. Great. Again, this one has the teaching points, kind of the thinking behind everything, right? Relationship structure is documented as a fact about the client's life, not as a clinical issue to be resolved. There's nothing wrong with polyamory or non-monogamy or whatever folks decide consensually to do with each other. It's, that's the theme is what is going on versus for the client versus whether that's the issue. Here we have a medication change tied to gender affirming care is documented the same way any other medication update would be. If your EHR forces a checkbox or demographic field that doesn't leave room for context, document the fuller picture in the narrative fields and let the checkbox carry only what's required. So that's just kind of, if you have a system or a format that requires you to check things off, that's kind of what you can do about it. Okay. Oh, let me just say this last bit. This approach applies to any population you feel protective of. So if it's a different, kids or something like that, like you can use the same strategy for any of those folks you feel protective of. Okay. So we had a lot of questions coming in about the golden thread continuity through an unplanned session. So like when we're, doing those like kind of structured things and formats and then the client comes in and is like, this happened this week and I just need to like unload, right? That would be different from the plan. And we're also, I think this is the one, I know this is an IFS one. We are going to get to how you would talk about, like a person-centered or Rogerian kind of a thing. That question is definitely answered in the FAQ that I'm sending out. You're going to get it here but I'll email it as well, but you're going to get it in the chat too. We'll just go through this one really quick. Ongoing weekly therapy using EMDR, anxiety, chronic self-doubt. Client arrives grief-stricken after the unexpected death of her dog 2 days prior. Clinician sets aside the standing EMDR phase work for the session and uses brief MI to help the client work through ambivalence about an upcoming decision. So you can see the before note, have the client come in, upset over the dog over the weekend. We didn't do EMDR, and just kind of, how this is going for the client. And here is our format. This one is much briefer than our previous two. This is another way you can go about it. Client came in session, the presenting overarching goal, issues and goals, anxiety, chronic self-doubt. Goals are to decrease anxiety-driven avoidance and self-critical thought patterns and increase distress tolerance and self-trust. Plan, individual sessions, EMDR IFS, all of those things. Clinician facilitated grief processing related to the unexpected loss of client's companion animal. Clinician observed decisional ambivalence regarding an upcoming related appointment and utilized MI to explore available options. So we're documenting the pivot and what we did. Notice that MI is not up there in my clinician plan, and that is okay. If I were to be asked, why'd you use MI? What's your background in that? I personally took MI in grad school, and I am a level 1 MINT certified MI practitioner as well. That's not my general way of conducting therapy, right? It's not my main modality, but I'm trained in it, but I don't have to justify that in my documentation. I know that. And this is like, did you read a book? Did you take a CEU? Things like that is sufficient. No assessments, referrals, medications, recommendations, and my, EMDR phase work at next session as acute grief response allows. So I'm making space for that pivot and then return to the plan. Check in on grief response next time and resume the standing EMDR treatment plan. And then we have our standard kind of end, no risks presented, client does not denied all the things. And these are, again, those teaching points around how I'm thinking about things. So let's talk about that golden thread, right? It doesn't snap when life happens. The golden thread is what is that overall picture of the client while in your care. So the golden thread is just talking about that. I'm going to stop sharing as I chat so I can see your faces. The golden thread is held not only in your documentation, it's held in your intake forms and how they signed consent for treatment. It's in how long have they been working with you. It's in the diagnoses that you've made or not made, right? Are you taking insurance or not? If you are, you need to have a diagnosis on there of some type. Uh, it's how you're the journey of those assessments and scores, right? So the golden thread is not just held within your documentation, it's within the whole chart that shows the story of the work. Um, and also, like the golden thread, if that's not a helpful analogy for you or a framework for you to think about documentation, that's okay too, by the way. If you're like, I'm so confused by that, what does that mean? You don't got to use it. If it doesn't work for you, you don't need to use it. So, um, let's take about 5 minutes to answer questions before we walk through the language format. I really want to get through that with y'all. I'm sure we're going to all feel like we're not going to get to every single question. We're probably not. I will do that FAQ. And I'll send it out. Well, you'll have the one from the up to today, but I will send out also one questions from today so that you can have those answers today. Okay, Lisa, let's see. We can do rapid fire here.
Okay. So there were a couple of questions from earlier. Where does a private practitioner know what's in the contract? I use Headway and Alma and assume they have contracted, and I don't have that specific info.
You should be able to ask for that information from whatever platform that you're using. I've used both of those as well, by the way. And it was a couple years ago, but it may actually be in there's a there's a screen that says which insurances you're paneled with, and I think you can pull the contract from there. But either way, if you can't, you can also just message like their IT, whoever they have for support services and ask them, where's the contract and can I see it? I want to make sure that I'm abiding by all of the rules of my documentation. They're going to be like, use our documentation, our EHR, and it'll be great, right? You don't have to. I never use their EHR, to be honest with you, other than what it was like the minimalist that was required to use it. They don't need my client's information. They don't need to submit it to their AI to learn from because that's what they're all doing, and that is a topic for another day. But just know that I'm actually going to send you an article about the Talkspace situation if you had not heard about it already. But you can fill it out whatever way you need. Does that answer that question, Lisa?
Yes.
Okay.
I feel like I did.
Yeah, I would just reach out. Good. Okay.
Yeah.
Yeah, just reach out to their support services. And if they tell you no, by the way, if they say no, you can't have it, I would be seriously pushing back on that. I'm going to be liable for being responsible for meeting in compliance with what this contract says, and you're not going to let me see it. That's going to be that would be a hard pass from me, to be honest with you. I would probably leave that platform.
I was kind of more worried to ask them because then I feel like I'm putting myself in their list of maybe clients to be auditing. Like if I reach out to Headway or Alma, I feel like now I'm in their list and I don't want to be in their list of whoever they randomly decide they want to be assessing in the ways they're doing it. So
they're not going to care. Actually, what I have learned, it was kind of disappointing. The lack of care that venture capitalists have on that stuff, they're not even thinking about that. Yeah. Okay.
Do we need to document health issues specifically? For example, new or ongoing cancer diagnosis, etc.
So I would, cancer diagnosis, yes, because that's probably going to impact the client's presenting issues and goals for treatment, right? So I document whatever those changes are that are tied to the client's presenting issues and goals, or do we need to update, right? So like, let's say the client is working on childhood trauma, family of origin stuff, and then they get this diagnosis, and now we're like, we're working on that, right? I'm going to document the change. I also don't think you have to put cancer diagnosis. Recent medical diagnosis change or recent new diagnosis is also sufficient if you want to be even more protective. Or, I mean, I don't know that putting a cancer diagnosis, right, like that's not protective, but if you wanted to be even more minimalist or withhold more, you could put that.
What changes do you make when documenting an intake session?
We're going to go through that in our guide that I'm going to show you right now. I actually have where that treatment plan section is. I have a formula of what I put in there that speaks to that kind of overarching piece. So you'll see that here in just a minute.
Okay, there's about 3 more here. Is there a reason you say goals versus client goals? Are they interchangeable or are you doing it for a specific reason?
I don't put client goals in it because I don't put client really in my documentation at all, and it's a known thing. I don't think there's any harm in putting that in there. Uh, but I don't put the word client in there. I just saw a question come up about the treatment plan. That is probably a bigger question. I think probably what you're asking is about that big plan overarching, and that's not something I have in a way that I could just like submit that to you. If you're talking about our section at the top of the note, that is your treatment plan. That is the plan. Okay. I'm going to go ahead and table the rest unless just so I want to make sure we can get to that piece.
Yeah, there's 2 more, but we can wait. Or you can take them now. Up to you.
Let's wait. Let me get through the thing and then we'll see if we've got time to answer them here live or we can, also, Lisa, if you have some of the answers to some of the basic if there's like a standard question that you know the answer to, you're welcome to go in there. So sorry, that is the wrong document.
Mhm.
Okay. Let me move it over. Yes, show me the whole thing. There we go. Okay. All right. So this is I'm not going to read through this whole first section, but this is our, you know, uh, language handout template. It's got the templates in it and all that stuff. You're getting that dropped in the chat and emailed to you today. Guiding principles for ethical and protective documentation is here at the top, and kind of how to orient yourself when you're out there on your own, right? This is the format as we have talked about it already today or over this whole course. Here's a simplified version you can copy and paste. Here's that initial intake. So really what changes, right, is this bolded section right here. Therapist review. What are we legally required to review? Informed consent, privacy, confidentiality, and limits to confidentiality, emergency procedures, therapy orientation, and assessed family, vocational, medical, legal substance use, trauma, and psychological histories. So let's pause here for 1 second. We're probably like, let's be real, in the first session, we're not going to get to all of that stuff, right? This is our overarching treatment plan for how we're creating the treatment plan. We're going to spend, the way that I view it is those first 4 sessions probably. I'm still getting a lay of the land of this client, who they are, what is their story, what's coming up for them, how are they in the room, right? And that just takes time. And for myself, and what I've told the staff and how I've trained them is we don't need to worry about nothing for like 4 sessions at least, as far as achieving something or what have you. It may or may not take 4 sessions depending on your process, but it takes the pressure off of the time to get there, right? To rush. So I was guest teaching at UT earlier this week, and a student asked me about oh gosh, what were they asking me? It was around oh, I got It left. Boomerang thought. That's what menopause is like, y'all. Get ready if you haven't gotten there yet. It'll come back, and if it does, I'll bring it up. Just know that we're going to be assessing for a while. Oh, I know what the question was. They had heard from another professor that there was no need for more than 8 sessions for any client. And if therapy was taking longer than 8 sessions, then there was a problem with what the clinician was doing in the room. And the student wanted to know my opinion. And I was like, I have a different opinion. And I said, here's the issue is that when we are oriented toward time, we stop, we are not oriented toward the client, right? So when we think about what we're paying attention to, if we've got a time component and the client really needs more time, their system needs to build trust, and we're working on relational trauma, you can't rush that. You can't rush a nervous system. It's going to do what it's going to do, right? We're rebuilding a relationship, and what is it like to be in a relationship when we're doing relational trauma? And that there's no time component to that. It just takes what it takes. That's one thing to kind of keep in mind too, is that it's okay if it takes 4 sessions. In fact, we're constantly updating a treatment plan or a case conceptualization in our own mind with new information. But this is kind of how we write that first part of those earlier sessions. And I actually leave it sometimes or start to populate it as I go, understanding what are the actual goals, because typically in that first session, clients are like, here's my presenting problem. And this comes from my medical background, but they'll be like, you go into the doctor and you're like, oh, I've got this thing on my arm, and I need you to look at it. And, but while I'm here, can you also look at this thing on my head? Right? Or I've been having this cough. Clients do the same thing, right? They're like, I'm here to work on this, whatever the major thing was that motivated them to call for therapy services. And then as we get to know them, they're like, oh, and also, I'm again kind of been dealing with this, and also I've got that, right? And so we want to let that allow for time for that to flourish and to emerge as the client has more trust with us. That's just kind of my thoughts on that. All right, let's go ahead. These are some examples. This one is in particular around identity exploration. So that should also be helpful for those wondering about that. Here's another one. This one is really about like chronic illness and what it's like to live with chronic illness, and invalidation of the medical system and things like that. And then we have another example. There's another example. There's 5 examples. So we talked about those troubleshooting and double checking questions. Here's a list of them, right? Did I document the client's orientation? So when you start worrying about, did I include enough information? Here are the ways you can check that you did. Kind of like, when we were kids and I gave you that way to double check your subtraction by addition or doing the opposite. This is a similar thing. Like, did I do the thing that I need to do? Okay. Alternative terms. So one thing I really love talking about is language. And so I have a very good friend who is a Princeton graduate with an English degree. And so her and I had a whole lot of fun coming up with these phrases that were talking about the thing without talking about the thing. So increased reliance on external regulation strategies. We might notice that. Engaging in repetitive patterns of escape or relief seeking. What is the behavior? I don't know. Could be drug use, could be alcohol use, could be laying in bed all day, could be I refuse to shower, right? Who knows what that is? I'm putting the overarching theme of what we're talking about. Use of external stimuli for mood stabilization, right? I got a lot of clients using a lot of stuff for, mood stabilization. So this is kind of where we're going, through how do we talk about? Up to now, we've been talking about what do we say? What do we say? What's included? This is where we get into the how do we talk about it? How do we say those words in that language? Habitual external regulation strategies. I know one we use a lot is maladaptive compulsive coping strategies, right? I'm talking especially with my substance use clients. Continuing on, this is like 4 pages of clinical terminology for sensitive topics. And there are areas I need to update this specifically for like gender affirming care and non-monogamy and things like that. And I will, when I update this, everyone who's taken any of my documentation training or the cohort is going to get emailed a copy of this of the updated version. Especially in light that, I created it a year ago, and in that year, well, we all know what the world's been like. So reproductive concerns, the emotional impact of fertility-related experiences, thoughts and emotions related to bodily autonomy. So this was right after Roe versus Wade, right? I was working with a lot of folks who were starting to make rash decisions around sterilization or things like that. And I just was trying to slow them down so that they were making a self-led decision, whether they, not because I have an opinion whether or not they should do that, they get to decide. I just wanted to slow them down so that it wasn't a reaction that they might later regret, right? That it was a measured, well thought out response or decision. I had a lot of folks talking about a lot of politics about Roe versus Wade, right? So those external personal values and external influences on reproductive decisions. I have a value that people have freedom of bodily autonomy, and the government disagrees with that right now. And I've got, some issues around that, right? So trauma and boundary violations, that can be assault, sexual assault, that can be childhood neglect or trauma or abuse. It could be a whole lot of different things, but the emotional impact of a non-consensual experience could be a whole lot of things, right? And it's really what we're working on is that emotional impact. And that would probably be a line I'd have in my presenting issues section, right? These are the presenting issues. Client is struggling with the emotional impact of a non-consensual experience. LGBTQI plus affirming language. We're gonna, maybe we're going to the presenting issue is the client is struggling with personal, relational, or social dynamics around this identity. That could be a client who family has rejected them, or I have a lot of folks in the LGBTQI plus community that are like, who I am is wrong and bad and is going to put me in danger. We have a lot of trans folks who are stealthing right now. I don't know if you've heard of that in this community. I know there's another version of that word that is also horrifying. But in this, what I'm referring to specifically is around stealthing in this realm is that they subvert or hide their gendered or transgender status. So it would be, a trans female maintaining a male presentation in public kind of a thing. We have some immigration and relocation, concerns. I have a lot of folks talking about that right now. Do I leave the state? Do I stay in the state? Kind of a thing. End of life concerns and grief processing. So I've had clients talk about their values around assisted suicide. I don't know that I want to put that in documentation necessarily, so I might write it in this way. They're not suicidal, but maybe they're have a terminal diagnosis, so they're talking about end of life topics. And I want to capture that in a way that's not that's more accurate and reflective of where the client's actually at, right? They're not actively suicidal, but they're coming to terms with maybe a terminal illness. Okay. We've got the topics. I'm going to blow through these really quickly. Again, y'all can sit with this. Next week, we're pretty much going to have just a wrap up of all the questions and how folks are feeling about things and what have we not covered that's really important. But we do have topics around systemic oppression and discrimination, chronic illness, disability, or medical trauma, neurodivergent clients with autism, ADHD, sensory processing, in light of, RFK wanting to have this autism registry thing, right? I may not want to put that in my documentation. We don't diagnose people with autism. We're not qualified to do that, so we never put that diagnosis in there. And I might do like a autism quotient assessment, just kind of as a, is there a there? Do I need to make a referral for our neuropsych or something like that, or bring in extra support? But we have got that topic. Political grief. Uh, we've got a lot of that going on right now. People are starting to come to grips with the country is never going to be the same. We may rebuild, but it will not be what it was before. And we have feelings about that. As we bring up that topic, take care of yourself too. Eco grief, right? Climate change concerns, living in a state in Texas. These are things I may not want to put in the client's documentation because I don't know how that might be used against them anymore, right? Like I used to have confidence, like, no, that'd be fine. This is documentation. It's inviolate, right? It's protected. I'm not 100% sure about that anymore, or that it won't be manipulated or twisted. So I may not want to put in there, the current administration or whatever. We've got reproductive rights affected clients. So maybe you're working with someone who is pregnant and they're really scared. They've had a lot of miscarriages and they're afraid. Like, what am I going to do if I have a miscarriage? We've got clients like that. Tech affected. So we've got some AI anxious clients. I really want to put some stuff in here around because it's just a newer phenomenon around AI psychosis and more about the AI stuff. But for the moment, we've got some tech affected. So maybe they've got, scrolling addiction, that kind of a thing. And then we have housing insecure, economically precarious clients, clients in unsafe states or regions. That would be Texas. Aging clients who are, elder caregivers. Maybe they're doing some of that legacy work. First gen, non-traditional students, religious deconstruction, high control group recovery. That can be from religious national Christianity, Christian nationalism. That can be quiverful. That can be, in fact, we have CNN put out a thing around Tradwives. That could be a whole lot of different things. High control can be domestic violence in some ways. We have cults, trafficking, exploitation, religiously minoritized. You think about pagans, Buddhists, Jewish in some situations, Islam, all kinds of things that can be marginalized. And then we also do have some ICE and state-based persecution. Oh, that's me. Me. And then we have all the stuff at the end, which is those regulatory compliance pieces. So if you're out there and you're like, I don't know, this still feels kind of scary. Am I really doing the thing? I have put the law in there of what the regulatory compliance is. Did you put this stuff in there? Because that's what they care about. This is the law. This is what it says. So we've gone through that stuff. So I'm going to pause here. We've got 12 minutes. And just like last time, we can hang out longer if we need to. That works for me. And the other thing I'll say is if we are going and you need to hop off, you've got a client or you've got, what have you, feel free to do so. We will upload all of this information just like we did this week. So, all right, let's open the floor a little bit. I know a bunch of questions came in and part of me is like, I got to get to them all. And I'm not going to be able to do that. So I'm just going to be okay with that. Lisa, let's go ahead and have you do that. And if Lisa reads out your question and I need some more clarity, I'm just going to have you pop off of the mute so that you can give me some more context. Okay.
Okay. If I am documenting a referral, say to a dietitian, do I keep this on the referral line if I believe the client needs to do it, even if we do not discuss each session? How do you document a denial of a referral?
Okay, wait, go back. Let me get one at a time.
Got it.
Okay,
I'm
so
documenting a referral, like to a
Documenting
dietitian. Do I keep it on the referral line even if we don't discuss it each session?
that's up to you. There's no right or wrong way to do that. I don't, but I'm comfortable with that. But you get to, if that helps you track the referrals that you've made, you can leave it on there. There's nothing about that that's going to harm the client or harm you or anything like that. If anything, it'll bring up some questions potentially of like, okay, so you've kept this on here. Why did the client go? Did they not go? Things like that. I tend to be more minimalist as far as like putting that stuff in there just for clarity purposes. I don't want to confuse what we're working on. But again, there's no right or wrong way to go about that.
How do you document a denial of a referral?
In that referral line where I said clinician made, whatever referral you made, and then I just put client declined at this time, period. That's something I have to note that I did my job and that the client informed me they were not going to do that. If they did that, right? If they said, a lot of times clients will be like, okay, I'll do that. And then they're not going to do it. And that's okay too. Did you do your job? That's what matters. Not whether the client followed through with it or not, other than, I think I talked about the anorexia case that I had last week. That's a little bit different because that involves safety. And so that maybe that I don't have that note anymore, but I might put in there client. I mean, I definitely uploaded the contract that we did as a document and then shredded it, right? Because that is part of the picture, the whole picture of the client. Okay.
And thinking about high needs clients, how do you document a denial of a sooner follow-up session?
Higher needs. Oh, like somebody you're going to meet twice a week or so? Yeah. So in that case, clinician recommended we move to twice weekly therapy, and client declined at this time, period.
Do you always list a modality evidence-based, or sometimes do you just say strengthened internal resources, processed recent stressor?
So I think this is one of those areas that gets into this idea of talk therapy. Talk therapy is not a modality. And that is what, we have talking therapies, right? That's true. We have body-based therapies. That's different, right? We have EMDR, which is a different kind of neuroscientific thing. I think that if we're not putting something on there that is evidence-based, then it brings up a lot of questions as to whether or not you're working within your scope of expertise. What are we doing there, right? So that's something to kind of think about is as you're going through these questions, what are the consequences of not doing that for you in your setting? So I always put, and I advise and recommend that everyone puts an evidence-based practice in there, right? Like, is it a real thing? Because and also I'll push back a little bit and put forth a question for you, which is resourcing is a modality, right? That's a thing that you're doing. Now, in EMDR, we call that a phase 2 session. Phase 2 is resourcing, right? So clinician utilized EMDR phase 2 resourcing, and then whatever the activity was, right? So I'm still within my modality, even if I'm bringing in a DBT skill, which is not a major modality for me. So I think that we are actually, and I'm going to imagine that each one of you are ethical and knowledgeable and trained, and that you're actually using a modality that maybe you don't have the language for of how to describe that. That's fair. But we can put, especially for some of the more like Rogerian, humanitarian, like humanistic, psychodynamic, that's more kind of exploratory. There's still terminology within that modality of what you're actually doing. And so feel free to use that. I don't think you need to change what you're doing at all, just maybe find different language for it, would be my recommendation. But again, that's what I do. Yeah. Okay.
Okay, last question. There were a couple of questions about the treatment planning cohort, but I'll give those to you, and I figured you could send those in the email. So when the presenting issue is substance use disorder and they have a documented alcohol use disorder, are you still using vague clinical language, or could you document utilization of harm reduction model track assessment using audit?
Yes, you can. You said something about documented. So let me actually go back to that piece. Who documented it? Because you're going to sign your license on that, right?
Yeah,
And so
I'm hopping in to clarify just for the question real quick.
Yeah.
I My specialty is grief, trauma, substance use, and sort of the intersection. So I see a lot of family members after a loss due to substance use, but
Gotcha.
occasionally, because I have that listed as a specialty, I'll get an active substance use case, right? And several times it's been folks who went through inpatient rehab, did IOP, and now are in outpatient looking for sobriety maintenance and support.
Hmm.
It's documented in their medical record a lot,
Yeah.
right? And some of them, especially alcohol use disorder, it's part of their own recovery, right? To through the AA program, right? Something like that. I am an alcoholic. It's part of their own self-identification.
Hmm.
I, because I didn't do the initial assessment, they're not actively using, so that it might be alcohol use disorder in remission or whatever that F code is, right? So if I'm not putting it, I'm in private practice, I don't take insurance. If I'm not putting a diagnosis,
Right.
but part of the way we're tracking their sobriety maintenance is I return to use and I use harm reduction model anyway. It's like I'm trying to figure out, is it more protective to just literally not mention what the substance use is at all and just use the coping language, that vague language that you used, or is it clinically more responsible or whatever? Should I
Yes.
be using the other language?
I gotcha. So typically in our practice, if another clinician outside of the practice has made a diagnosis, I don't add it because I didn't make that diagnosis. And for me to add that, I didn't do that assessment, right? I don't know that I agree with that diagnosis. Um, and to sign it myself with my license, I'm taking responsibility for that. That's kind of how I view that. So we don't add any diagnoses that we have not actually made within our scope of expertise and qualifications. I never put in my documentation and have never put in my documentation the specific substance or what have you. I always keep it vague because it's irrelevant. And actually, you talked about really he's exploring his identity. Who am I as a sober person? What is this world, right? Those are right. It's still true. The high level view of it is true. Um, and accurate. So I don't put those diagnoses on there. And if you're in private practice and private pay, right, not using insurance, you don't have to put that diagnosis on there at all whatsoever. Now, the caveat to that is if the client wants, say, uh, a super bill for out of network benefits. They have to have a diagnosis. So, I ask clients, like, do you want to, you submit for, do you want to have that option? Because if you do, I'm going to have to put a diagnosis on there and we have a conversation about that. I will say everyone in our practice initially, in order to bill insurance, gets that handy adjustment disorder with anxious and depressed mood because I haven't seen them yet. How can I diagnose them with anything? And yet insurance requires it. So that's kind of how we go about that. We had a couple of years ago a dad who wanted to bring his 16-year-old in to be seen by us who had been diagnosed with borderline personality disorder by a psychiatrist outside of our practice. I'm not sorry. Katie, I happened to be looking right at you when I said that, and that I had the same reaction. And he said, so I'm going to need that put on her record. And I said, well, we're not going to do that. And he really pushed for it. And I was trying to figure out why does this matter to you? And he's like, well, a psychiatrist made it. And I think there was some hierarchy, right? Like a psychiatrist is above a therapist or whatever. And I said, I'm not going to do that. In part because what I know about young women is they are massively overdiagnosed with borderline personality disorder. So it's protective of your daughter to not do that. And number two, all teenagers have personality disorders pretty much. That's why it is out of the scope of practice and recommendations and expertise to diagnose a teenager with a personality disorder, and I won't do it. And he took his kid elsewhere, which is fine by me because I'm not going to compromise on that as a strong belief of mine. So I see the nods. I love that. We're all on the same page on that. Katie, I hope that was a helpful answer. But yeah, no, I don't put it on there. It's not necessary. Yeah. Okay. It is time. If you have to hop off, totally get that, or we can stay. I know some folks had questions about the treatment planning cohort. So let's go ahead and go into that. Elisa, were those questions dropped in there in the chat?
We answered. You got to all the
Oh,
questions.
okay. About the treatment planning as well?
Oh, they were in the chat. I have them. Do you want to go ahead and answer them?
Yeah, unless people just want to like, I mean, we're, just a few of us. If you want to hop off
Yeah.
of mute and just kind of ask, that's fine too.
Yeah.
Um,
Sorry.
Yeah, Michael.
no, go ahead,
I was
Michael.
just gonna say I was one of the questions because I just like scheduling wise cannot be in the treatment planning cohort, but I'm really like interested in doing it. So I just wondered if you like expect to maybe offer the same thing in the future.
I do. And I'm actually looking at some for the fall, but it may be spring before I offer it again, just in part because my fall is already full and I'm trying to not pack it even more because that's what I tend to do. So yeah, totally. And one thing I'm thinking about doing as well is figuring out if there's a way that I can do it like as a course or something, right? So that people can do it asynchronously and all of that. That's really that it's a tech issue. Finding platforms that do that is not that easy actually, and they're very expensive. So anyway, yes, I am planning on doing it again, and a couple different ways. So yeah. Yeah. What else?
Yeah, that was kind of the other question was asking if they can sign up and then watch the video later when they're able to.
I'm thinking on that. It's more about uh I haven't thought about it, I guess. And so that's kind of a tech thing too. So I'm going to answer that. Let me answer that in the email that I send out this afternoon. Does that
Okay.
work? Okay. I'm going to write that down. Um,
And then people were also wondering where they could find the discount. You had mentioned something about a discount earlier.
yeah, I'm going to send that out in the email as well
Perfect.
because I don't remember it off the top of my head. Yeah. Anything else, y'all?